B lines evaluation in the acute cardiac care. And I'm going to build my presentation on a short definition, then how to assess the B lines, only at rest or also at stress, B lines in the guidelines, B lines in different emergency clinical situations, lung ultrasound guided in heart failure patients, and last but not least, the prognostic meanings of B lines in acute cardiac care. So let us start with the definition. What are the B lines? They're also called, lung comets. Why comets? Because comets pass through the sky just like the B lines pass through the ultrasound image of the heart. And so this is a very nice association. So the B lines are these discrete, laser-like, vertical, hyperechoic artifacts that arise from the pleural line and move synchronously with the lung sliding. The multiple and diffuse B lines are the sonographic sign of the pulmonary interstitial syndrome. So the ultrasound appearance of the normal lung, the one that is filled with air, is usually like an almost black image, as you see here, with these artifacts from the pleural lines that are called the A lines. When we get more interstitial fluid into the lung, then we could see the B lines as you could see here. The more the fluid, the more the B lines, till the point when we get to a multiple and confluenting B lines and the whole image, normally black, starts to turn white with this multiple and confluenting B lines, and this is very typical for the pulmonary edema patients. Now we come to the question how we assess the B lines, and here I would like to say and impress again and again that it is a very, very easy ultrasound method. If we have a hierarchy of the ultrasound methods, like the hierarchy in the education, then the level of the lung ultrasound will be like the one of the kindergarten. Also, I would like to say and to impress that you don't have to have very complicated equipment, and you could search for the B lines with any echo probe that you have. You could use the complete scan with the 28 sites on the lung. These are typically on the anterolateral chest, as you see here, from the second to the fifth intercostal space. And then in these sites, you just count the number of B lines. As here you see 1, you see 2, 3, 5, etc. Now an example with 2 patients with B lines. You see here that they are very moving. They come in and come out of the image. They move synchronously with the breathing of the patient and with the sliding of the 2 pleural lines. If you want to measure the maximum number of B lines, you have to freeze this image at the moment when you see the maximum number of the B lines and then just count them. Here is another example of a very sicker patients, that the ones that I shown you before. You see that there are multiple, definitely more than 10 B lines. They're confluencing, and you probably don't see any black space in this lung field, the entire field is turned into white. And if this is multiple at many sites, then you could say that the patient has a pulmonary edema. So, do we have to assess B lines at rest or at stress? To this question, I would answer both is better. Why so? Because many of our patients do not have complaints at rest, but they have complaints, breathlessness, fatigue during physical exertion. And then if we study the lung ultrasound only at rest, we would find the normal image of the lung with only the A lines. And if we exercise even a little bit this patient, we could see the B lines and make the connection between the symptoms of the patient, his breathlessness or her breathlessness, and the appearance of B lines. Of course, you would say the 28-site complete scan of the B lines is very cumbersome for a stress situation. Of course it is, you are right. There are simplified protocols for scanning only 4 sites when you stress the patients or when you do a stress echo. And these sites could be in the third intercostal space, be laterally in the anterior and middle axillary lines. Why exactly these points? I would answer to this. In our study group, Stress Echo 2020, we have performed a complete examination with stress echo with all of the 28 sites evaluating during a single stress echo session. And we were able to find that B lines tend to accumulate in certain points, the so-called wet points of the lung, like you see here, and these are namely the third intercostal space, anterior and middle axillary lines. And if you want to do a stress test to your patient, you could concentrate exactly on these areas without losing diagnostic accuracy and with saving much of your time. I would like now to demonstrate a very beautiful one and very recent from this year study about the hemodynamic basis of lung congestion during exercise in HFpEF patients. The authors here have been able to prove that the extravascular lung load accumulates due to both an increase in pulmonary capillary wedge pressure leading to fluid filtration, and this could be due to left heart failure, but also and more importantly to an increase in the central venous pressure and an impeding of lymphatic drainage which comes from the right heart failure. Also, these authors have demonstrated that those patients who developed extravascular lung water during exertion, they have twice as common RV dysfunction during stress compared with the patients who do not accumulate extravascular lung water. And the former group, they also have higher pulmonary artery pressure and pulmonary capillary wedge pressure. This is very, very important for our patients. Let us see what do the guidelines say about the B lines. First, there is a 2015 guideline of ESC for the acute heart failure, and in this guideline there is a very nice scheme. In this scheme, when you exclude first the patients with shock or those necessitating some resuscitation methods, then you come to a standard diagnostic algorithm, which includes the ECG, the lab test, the chest X-ray, and also the echo, both of the heart and of the lung. And it is recommended in this guideline to use the bedside thoracic ultrasound for detecting the signs of interstitial edema, and the same text is also integrated in the 2016 ESC guideline for the management of acute and chronic heart failure. And now I come to some of the more interesting parts of my presentation, B-lines in different emergency situations. You know, when you work in an emergency department, you see many patients who are ill, who need to be addressed immediately. In this situation, B-lines and lung ultrasound could give you many useful tips. For example, if you have a patient with acute dyspnea, very easy when you use the lung ultrasound is to make the differential diagnosis between a patient with the exacerbation of COPD, where you have the normal lung appearance with the A lines only, and the patient with acute pulmonary edema, where we have multiple diffuse B lines. Another very useful differential diagnosis, I would not go in many details, it is coming later in the session, is about acute cardiogenic pulmonary edema and acute lung injury like ARDS. As I have said, in the cardiogenic pulmonary edema, you have multiple and diffuse B lines, while in ARDS, you have again the B lines, but you have also this typical subpleural consolidations like you see here. And also you have, very importantly, the spared areas, which are defined as areas of the lung that are areas of the lung that are normal but are surrounded by other areas with multiple B lines. Another very critical and difficult situation in the emergency department is the patients with shock. We have a special session dedicated to this. I'll just very briefly come to what we could do with lung ultrasound and multi-organ ultrasound. Of course, here we start with the heart. We have to orientate for the function of the heart. We have to exclude major events like tamponade, like massive pulmonary embolism, like a cause of obstructive shock. Of course, we have to exclude also pneumothorax, which is the topic of the next presentation. And then we search for the B profile, multiple and diffuse B lines. If we found this kind of B lines, this is probably a cardiogenic shock. If we do not find them, we could start with a diuretic therapy. And if the patient improves, that is probably a hypovolemic shock. If it deteriorates and the B lines appear, this is probably a septic shock. And another emergent situation in the emergency department is when we suspect a pulmonary embolism. Again, a different presentation is coming later on this topic. Just very briefly, here combine point of care, multi-organ ultrasound, heart, lung, and veins, and this increases the sensitivity to almost 90%. And if you combine the use of the standard diagnostic strategy with the multi-organ point of care ultrasound, then you several hours after admitting the patient to the emergency department, you will be able to increase the right presumptive diagnosis in much more higher proportion of patients compared with the standard approach only. Now, we come to the less guided treatment in heart failure patients. Do you know that lung ultrasound has proven to be more effective in diagnosis acute heart failure than chest X-ray and NT-proBNP values in the emergency department? Yes, it is true, and it has been nicely demonstrated in the study published in the European Journal of Heart Failure just this year. In this study, the authors include more than 500 patients, and they use these ROC curves and the area under the curves to evaluate the diagnostic accuracy of different approaches. And as you see here in these ROC curves, the addition of lung ultrasound has a higher accuracy than clinical evaluation alone in identifying acute decompensated heart failure patients. In contrast, as you see here, the addition of chest X-ray and NT-proBNP did not significantly increase the accuracy of clinical evaluation alone. And in these vast curves, you could see that the diagnostic accuracy of the lung ultrasound integrated approach was higher than that of the chest X-ray and NT-proB approach. Combining the less ultrasound with the clinical evaluation reduced the diagnostic errors by 8 cases per 100 patients as compared to 2.4 cases for 100 patients for chest X-ray and NT-proBNP strategy. And another very useful and elegant study performed in the follow-up and care of patients with B-lines. This is the LUS heart failure study here. 123 patients after dehospitalization for an episode of heart failure have been randomized to a LUS-guided follow-up strategy and to a standard guided follow-up strategy. In the LUS-guided strategy, the investigators were prompted to search for B-lines as a signs of subclinical pulmonary congestion and to titrate the diuretic therapy. And as you could see, the primary composite endpoint, which included hospitalizations for heart failure, urgent visit, and death during follow-up, was experienced by fewer patients in the less follow-up strategy versus the control group. And the largest contributor to this difference was the number of visits to emergency departments due to worsening of heart failure. And a very important thing to say, the number needed to treat or to follow up with a less guided approach was only 5 to prevent one event during follow-up. And last but not least, I would like to say a few things about the prognostic meanings of B-lines in acute cardiac care, and I would demonstrate this with a very nice and recent study from this year published in JACC Heart Failure about the lung ultrasound in acute cardiac failure. In this study, the authors have included nearly 350 patients which have been hospitalized for an acute heart failure episode. The authors have used the 4-zone lung ultrasound performed early during admission and at discharge, and their hypothesis was that LUS may offer a more reliable method of assessing pulmonary congestion in patients with acute heart failure compared to the clinical signs of congestion alone, which included auscultation, weight, and urine output. And also they studied the prognostic meaning of late and later B-lines. So they compared 2 methods for evaluation of B-lines, the 8-zone and the 4-zone methods, and they were surprised to find that most of the patients had a measurable number of B-lines on the simplified 4-zone 4-zone lung ultrasound after admission, despite these patients having no radiological or clinical signs of pulmonary congestion. The risk of an adverse in-hospital event increased with the rising number of B-lines, as you could see in this table, and this included the hospital length of stay, the all-cause death, the ICU admission, LV assist device, and the use of intravenous inotropes. And the odds ratio for each tercile of B-lines was 1.82, and this was very highly statistically significant. And I would like to say to you a very important thing. This connection, this association between the number of B-lines and the short-term outcomes in this patient persisted even after adjusting for important clinical variables such as NT-proBNP. During the course of the hospital stay, which was 6 days, the number of B-lines decreased from a median of 6 to a median of 4. But you could still see in this graphic that more than half of the patients were discharged with at least 4 B-lines. And this is very, very important, dear colleagues, because, as you could see, the risk of heart failure hospitalizations and all-cause death was greater in those patients who have higher number of B-lines at discharge. And again, this persisted even after adjusting for important clinical variables such as NT-proBNP. And now I come to my take-home messages, which are that lung ultrasound is an affordable, accessible, easy-to-use, and fast method to evaluate patients in the acute cardiac setting. The simplified imaging protocol, which includes 4 sites, is not worse than the more complete ultrasound protocols with more B-lines, and it allows for rapid and repeated assessment of patients with heart failure. Also, lung, as we have seen, has been proven more effective in diagnosing acute heart failure than a chest X-ray and NT-proBNP in the emergency department. Lung ultrasound may be a useful tool to triage patients early during hospital admission, and the reduction of the number of B-lines may seem to be an obvious goal of therapy. Studies on the prognostic significance of B-lines suggest that the presence of more than 3 B-lines at discharge is associated with a higher risk of readmission for heart failure or death during follow-up, and this is very important for follow-up of our patients. And also, loss-guided follow-up improves the prognosis in our patients with an episode of acute decompensated heart failure. And maybe my most important take-home message for you is that assessing B-lines, seeing the lung comets is very easy. You don't need any special equipment, and if you have not yet done it, just do it. Thank you so much for listening to me, and enjoy Vienna in this pleasant time of the year. Thank you.
Thank you, Dr. Simova, for this great comprehensive lecture. So I will invite the audience if you have any questions for this really nice talk.
Does this B-lines is good for chronic heart failures? Patients who have chronic heart failures, at times they are lying supine, and if you examine them, at times you do not find any creps on your clinical examination, but the P lines would be there in chronic
Yes.
heart failures.
Thank you very much for this question. It is a very nice one. Of course, they have their meaning even in this situation. It is very useful and very easy just to put your probe on the lung of the patient and see how well he is doing. And this is particularly true if you have previous image of the lung, and then you could very easily titrate your diuretic therapy because they appear or disappear earlier from clinical signs of pulmonary congestion and decongestion. So what we could do with B lines in our chronic heart failure is to titrate the diuretic therapy in order to prevent further worsening of their condition.
Okay, thank you. More questions? Virginia.
Thank you, Jana. It's a wonderful presentation, very comprehensive and elegant. What is the information provided, the additional information provided, if any, by pleural effusion in your lung ultrasound scan?
Oh, it adds, of course, to the B lines. This is maybe a little bit worse situation when you, apart from the B lines, have the pleural effusion when the lung get consolidated, and of course this is worse for our patients, and we have to be more aggressive in these situations.
Thank you. Just one question for this stress echo. What is the meaning and what is the cutoff of increasing of B lines for the diagnostic of early signs of heart failure?
So thank you. This is a very difficult question. In the last guideline with the first author, Patricio Wansewarty, the cutoff for B lines for saying that, yes, it is a positive stress echo for B lines was 5. But he used the 28-side scan. In our study, we have used the simplified scan because we have proven that it works. This simplified scan works. And in our simplified scan, we use the cutoff of 2. So it is much, much easier to do the stress with 4 sides and with the cutoff of 2.
Okay, this is nice practical advice.
Thank you.
So if there is no more questions, we can pass to the second. Okay, doctor, please.
May you come, excuse me, may you come to the microphone and introduce yourself before the question? Thank
Dr.
you.
Kobalova from Georgia. Thank you for brilliant presentation. What kind of stress test do you suggest? What kind? Bicycle, dopamine, treadmill?
Okay, thank you again. This is a very useful question. The most physiologic one is exercise, but of course you could also use vasodilator or also dobutamine. But if you don't have so much time, I have used it and I have seen it. If you have a patient in your emergency department or your ambulatory practice, just make him do some physical exertions, yes, 10 times to go to the floor and then again, and you see that if the patient get breathlessness, get fatigue, and you put your probe to the lung, you would see the B lines. So you may use from the most complicated to the most easy ways to just to see if your patient, maybe you are thinking if your patient have PEF or not. He has complaints at stress, and you see him at rest, and you don't know what happens at stress. Just make him do 1 stairs up and down. Come back to your office and see the B, and see if he has B lines. If you don't have the special equipment for stress echo, like bicycle ergometer or treadmill, or you don't have dipyridamole and you don't have dobutamine.
Thank you.
So we just heard the patented smart cardiologist stress test for lung ultrasound. We are grateful for this also. Thank you, Jana. And
Thank
we
you.
can move
Thank
to
you
the
too.
next.